Okay, so without further ado, we have our next session, Social Approaches to Engagement in 10-10-10 or 10-20-30. We have a variety of social scientists up here, kind of piggybacking of what Margarita said earlier about our intentionality around geographic locations. We're very intentional about having a diversity of disciplines among these social scientists, sharing their innovative work with us. And so we're going to start off with Dr. J. Sevelius. Dr. Sevelius is an associate professor with the Center for AIDS Prevention Studies here at UCSF. She's also a licensed clinical psychologist here to share her work with us. Thank you. Please welcome J. Sevelius.
Thank you, Will. Thank you all for being here. It's such an honor to be able to present my research to such an esteemed group of colleagues at a social and behavioral science-focused event. This is my community-based research team, without whom my work would not be possible. This is really the heart and soul of the research that I do. And what we aim to do, it really speaks to what Dr. Auerbach's talk spoke of earlier in terms of bringing a social justice lens to a field that often privileges biomedical ways of knowing, often to the detriment of communities, in particular transgender communities and communities of color who are most severely impacted by the HIV epidemic and who are often left behind in our efforts to address it. So in my talk today, I'm just going to briefly acknowledge the extreme health disparities faced in particular by trans women and by trans women of color, and discuss the impact of the invisibility and erasure of transgender people and transgender women in particular from HIV research and services. And then I will discuss a trans-specific theoretical model that we've been developing to inform intervention development. And then finally, I'll present an intervention that we used the model to develop a community-driven intervention called Sheroes to demonstrate how gender affirmation in particular can be operationalized in an empowerment approach for addressing health disparities among trans communities. Transgender women experience extreme disparities in the HIV epidemic. They're 34 times higher odds of infection than the general population in the US. According to the CDC, they are the highest percentage of newly identified HIV cases in many parts of the US. In San Francisco in particular, transgender women have almost 3 times higher community viral load than non-trans adults living with HIV, and African American trans women are disproportionately affected. There are also tremendous disparities among other psychosocial dimensions, such as depression, suicidality, trauma, and substance use. Among trans women living with HIV, they are less likely than non-trans adults living with HIV to take antiretroviral therapy. And among those who are taking ART, they report lower rates of adherence, lower self-efficacy for integrating ART into their daily routines, and report fewer positive interaction with their healthcare providers than non-trans adults. Trans women are also being left behind in the research and the rollout of PrEP. There are very low levels of awareness of PrEP, even in places like San Francisco, where we have stronger medical and social supports for transgender people. We still don't have trans-specific guidance for implementation. Trans women are excluded from or underrepresented in PrEP demonstration projects. And when they are included in observational studies, which is quite rare, they're very often aggregated with men who have sex with men without consideration for trans women's unique sociocultural contexts. And of the existing clinical trials, IPREX is the only one with confirmed enrollment of trans women. So in the IPREX study, the initial IPREX publication reported the 12% of their sample who initially explicitly identified as trans, but when reporting the results, they did not disaggregate the trans women from the men who have sex with men in the study. So we worked with some of the investigators from IPREX to conduct a sub-analysis of the data, which revealed zero effectiveness on an intention to treat basis among trans women in the study, which is likely due to adherence issues. So the point is that when we don't disaggregate trans women from men who have sex with men in the way that we collect and report the data, we're likely to miss really important information. And I'm not saying this because I think PrEP doesn't work for trans women when they do take it, because the study did show that among those who took PrEP, who had detectable drug levels in their blood, they were protected. But there are clearly adherence issues and other things going on, including potential concerns about interactions between PrEP and hormones that might prevent or dissuade trans women from taking PrEP in the way that the men who have sex with men were more successful in doing so. So this common practice of collapsing trans women with men who have sex with men in HIV research can actually perpetuate the disparities that we see in health outcomes. Trans women are not men. They have very unique sociocultural contexts in which they are engaging or not engaging in HIV care, in which they're making decisions about whether to take PrEP and how adherent they are. But they are often treated as a subset of men who have sex with men in HIV research, policies, and service. And this leads us to make erroneous conclusions about what we know and don't know about trans women and their needs. So for example, a recent article was just published in AIDS that included trans women as a population of focus in the title. But you have to read the article, not just the abstract, to discover that the study included 557 men and 4 trans women. And so no comparisons can be made or unique information can be gleaned from this study about trans women or offers anything unique or adds anything to the literature about trans women, but the title is really misleading. And so this is a really common practice in the HIV literature that may be well-intentioned, but it actually perpetuates invisibility of trans people and misunderstandings about what we know and don't know about trans people. So to address these gaps in scientific knowledge, my research team has focused on understanding trans women's unique HIV prevention and treatment needs and developing and evaluating interventions that are trans-specific in order to meet those needs. So through qualitative inquiry from multiple studies, we've been able to identify trans-specific themes repeatedly cited by trans people when talking about barriers and facilitators to HIV treatment engagement, to PrEP uptake, and medication adherence. And these themes largely center around prioritization of transition-related healthcare, which is hormones, surgeries, really prioritizing things that are affirming of the person's identity, needing their providers to be trans-informed and trans-affirming. They also want to be educated about ART and PrEP and the potential for any interactions between medications that they're taking and their hormone therapy. Because what we hear time and time again is if there are any perceived interactions, that it's the ART and the PrEP adherence that's going to suffer over the hormone therapy. So my early qualitative data from interviews with transgender communities highlighted the importance of gender affirmation. Gender affirmation, hello. Being the social and or medical affirmation that transgender people receive for their gender identity. And so this gender affirmation was really highlighted in the qualitative work that I initially did when building this model. And 2 constructs within the overarching concept of gender affirmation emerged in this data. The first is importance of or need for gender affirmation. So this was really variable among the trans people that I talked to. The desire for transition-related procedures such as hormones or surgeries varies within transgender communities. For transgender women, the desire to be affirmed as female as opposed to being out as a transgender person or really identifying with transgender communities also is really variable. The desire to quote-unquote pass or live stealth, to live separately from trans communities, is also variable. The second construct was satisfaction with or access to gender affirmation. So how much access does that person have to gender-affirming healthcare, whether that's directly transition-related or whether it's just primary healthcare or HIV healthcare that affirms the person in their gender identity. Affirming relationships, so the access to and satisfaction with relationships that affirm that person's identity, whether it's family, peers, sex partners, lovers, that affirm that person for who they are. And then a natural ability to pass or access to quote-unquote passing varies a lot within transgender communities. So these were two dimensions that varied and not necessarily together with the people that we interviewed. So what emerged from this data was a theory that the people who experience the highest need for gender affirmation, but the lowest access to it, are going to end up exhibiting the highest risk. And that risk, that kind of risk behavior is really serves the person to meet the gender affirmation needs that they're not getting met in other ways. So that might be taking hormones without prescription. That might be using injection silicone to shape one's body, or it might be sexual risk behavior to get one's gender affirmation needs met, or just not engaging in self-care behavior like adhering to HIV medications. So the people with the highest need for gender affirmation but the lowest access to it were likely to exhibit the highest levels of risk. This is the overarching model of gender affirmation. This is just the entire theoretical model that was published in Sex Roles. And I just put this up to talk about how psychological theory, social psychological theory, and other theories, Rafael Diaz in particular, he talked about how oppression can lead to sex in high-risk contexts, how these theories can be built upon to inform a population-specific theory of why transgender people in particular might be experiencing the level of health disparities that we see. So some of the most recent data supporting the model of gender affirmation comes from a HRSA-funded Special Projects of National Significance initiative led by Greg Rebchuk here at CAPS. And it's the largest multi-city cohort of transgender women of color living with HIV to date. And in bivariate logistic regression models, those who reported higher levels of importance of or need for gender affirmation were more likely to report clinically significant levels of depression, while those who reported higher levels of satisfaction with gender affirmation and body satisfaction were less likely to report clinically significant levels of depression. And those who reported depression were significantly less likely to be adherent to their antiretroviral medications. Then higher levels of satisfaction with gender affirmation and body satisfaction were associated with higher likelihood of being retained in care. Both importance of and need for gender affirmation were associated with being virally suppressed. Other researchers' work have looked at how meeting transgender people's needs for gender affirmation leads to improved health outcomes in a variety of psychosocial and quality of life, decreased sexual risk in these dimensions. So when thinking about developing interventions to interrupt this relationship between transphobia and stigma and poor health outcomes in the context of social oppression and stigma, we've looked to building on the resilience that we see in trans communities and protective factors, such as building social support, identity pride or pride in one's transgender identity, coping, especially coping with transphobia, and of course building on the foundation of gender affirmation and increasing one's access to it. And we've seen that this does indeed lead to better health outcomes. The first intervention that we developed was called Sheroes. This was developed in collaboration with transgender communities. It's a small group level intervention that's peer facilitated for 5 sessions, and it's a mixed HIV status group, and it focused specifically on trans women of color. So these are just some examples of objectives of the different sessions, how we operationalize gender affirmation in the context of an intervention like this. And a lot of it is about explicitly affirming trans women's identities through social connections, connecting them with their community's histories and role models, and also through providing trans-specific information and exploring contexts of risk and resilience that are unique to trans women's lives. This is the initial data from the Shero's pilot randomized control trial with 89 participants. And you can see that at a 3-month and 6-month follow-up, the people who participated in the Shero's intervention as compared to a time and attention matched control group were less likely, reported fewer partners with whom they were having unprotected receptive anal intercourse. So sexual risk behavior was reduced in the Shero's participants at 3 and 6 months. A couple other interventions that we've been working on, informed by the model of gender affirmation as well as healthcare empowerment, were our Healthy Divas, which is also peer facilitated, and this one is specifically for transgender women living with HIV. And Triumph is our newest intervention. It's part of the first PrEP demonstration project initiative to focus specifically on trans communities. We're really happy to be partnering with La Clinica de la Raza in Oakland to be bringing more trans-specific PrEP services to the East Bay, and also Gender Health Center in Sacramento, another area that has lower levels of service that are trans-specific, and bringing PrEP to them as well. We're funded by the California HIV/AIDS Research Program. And I'll just end by saying that ultimately, my research is about seeing and affirming trans people as the unique and resilient people that they are, finding out about what matters to them, and involving trans communities meaningfully in the design and implementation of research that significantly contributes to improving their health outcomes. Thank you.
Our next speaker is Sheri Lippman, who is an associate professor of medicine here at UCSF, and she is an epidemiologist, sharing her epidemiological perspective with us on these approaches.
Thank you. Great. All right. And I'm a shorty. There we go. Nothing's coming up on the screen. Oh, there it is. Thanks. Okay, great. Well, I really appreciate the invitation to come and speak to you today. In this panel, we were tasked, each of us, with talking about a different social science approach and how our specific disciplines really lend themselves and how they're operationalized into addressing the HIV prevention and treatment cascade. So I was slated to talk about community mobilization and 10-10-10, but I work in South Africa where we're not there yet. We're still in the 90-90-90. And I'm going to get to community mobilization a bit in this talk, but I want to start a little further back and talk about the discipline that informs my work, that's social epidemiology, and then sort of how we're studying the social context and modifying it to impact the 90-90-90 goals in South Africa. So, as noted, I'm a social epidemiologist, but I'm kind of a mashup of a social epidemiologist and an intervention scientist, and what we do here at CAPS is interdisciplinary. But part of the work of social epidemiology is to identify and define those social environmental influences that impact our health, to investigate the pathways through which these social environmental factors are impacting our health at the individual and the community level, and to figure out how to address those social environmental factors to make people and communities healthier. So we're looking really at upstream factors in populations, and my work specifically looks at some of the social resources in communities and how those impact health and how we address those and strengthen those social resources. So I just wanted to do a quick slide on what we're dealing with. This is population-based data from a seroprevalence survey that colleagues here at UCSF and UW collected in 2014 in the Northwest Province of South Africa. And without getting into too much detail here, since everyone has seen a cascade that looks like this before, I do want to point out just a couple of the gaps that we're aiming to shore up with the work that we're doing. So in this seroprevalence survey that represents a population of about 80,000 people, we found that approximately 23% of the population was HIV positive, that among positives, only 75% of women and less than 50% of men actually knew their status if they were HIV positive. We noted that while people eventually show up in care, often when they get sick, a very small proportion of them actually come within the 3-month window that's recommended. That was about 60% of people who knew their status that came at 3 months. We have people obviously falling out of the care cascade at retention. A lot of folks said that they were adherent to their medications, but then we also have really dismal viral suppression in this community. So to address the major gaps in testing and treatment, we identify the social contextual factors that shape people's community and their community's ability to address their care needs. So the work I do really focuses on that last column, on creating supportive environments and addressing some of those social norms that keep people from care, including things like stigma and masculine gender norms that put men and women at risk. And also in really shoring up those community resources and the social resources to be able to engage in care, including creating shared concerns around HIV as a community problem, generating social cohesion and collective efficacy so that people can really engage in HIV testing and treatment. So among the social constructs that have been described and associated with community health over the years, ideas of collective efficacy, social cohesion, and social capital are a few that the social epidemiologists and other social scientists have focused on going back to Durkheim in the late 1800s. And the general idea is that to tackle social problems, communities need some level of working trust and mutual expectation to intervene for the common good. So teasing apart the various social constructs is really the subject of many books, and I'm not going to go into it in a 15-minute talk, but I want to focus in on this talk really on social cohesion, just one of those aspects, which really gets at shared values, ties to a community, that could be a neighborhood or an identity community, and a sense of sort of stick-togetherness that really feeds and fuels social cooperation. So here's a quick example of some of the findings around social cohesion from my research in South Africa. And I want to note that there's really not a lot of research on these constructs at a community level in sub-Saharan Africa, where the HIV epidemic has hit the hardest. We measured social cohesion in 2 large population-based surveys of 18 to 49-year-old residents in 2 areas of South Africa. One was the Northwest Province. That was the Cascade data I showed you a second ago. That's close to 1,000 people in that survey, representing 43 areas. And the other was in Mpumalanga in the Bushbuckridge sub-district, with just over 2,000 people representing 27 villages. And we created mean cohesion scores, and so these are group level scores by averaging individual scores within areas of residence. And we asked items such as, people in this community are willing to help their neighbors. This is a close-knit community. People in this community can be trusted. And what we found is that group cohesion was much, much higher in Mpumalanga than in the Northwest. In fact, group scores barely overlapped in the Northwest and Mpumalanga. So we also look at some of the risk behaviors in these areas, and this, you'll see here that heavy drinking and HIV testing really differ in these 2 communities, both of which are really shaped by the social context. So heavy drinking is far higher, and HIV testing is far lower in the Northwest Province than in Mpumalanga. So these are really different areas of the country with a different settlement history, different economic opportunities and social patterns and different ethnic groups. But at the base of these differences, there's got to be something in Mpumalanga that's deterring risk behaviors in these communities. So we looked at the association of social cohesion and risk behaviors to look at whether there were differences by study site. And we found that group cohesion didn't demonstrate a significant protective effect on outcomes in the Northwest Province. In fact, it was associated with lower reporting of HIV testing among women. But in Mpumalanga, where group cohesion was much higher, we see protective associations of group cohesion. So the odds of men being heavy drinkers were reduced by 40% for each additional unit of group cohesion, and the odds of reported testing in the past year were 1.6 and 1.9 times higher in men and women, respectively, for each unit of difference. So what this implies is that there are benefits of group cohesion when there's some baseline level of cohesion to start with, and maybe there's a minimum threshold required for group cohesion to play a positive role. And I put that little pharmacy sign on the slide just because while the threshold concept might sound complicated, it's really just like taking an aspirin. So you can't take 10 milligrams of aspirin and expect it to make you feel better. You need a proper dose of aspirin. You need to start with the proper dosing. So you'll start probably feeling the benefits at 100 milligrams, and you might feel better as it moves up from there, which I think is probably what's happening here in these social contextual factors as well. So now I'm going to get to the community mobilization part of the talk. So together with colleagues from Sanke Gender Justice, which is a South African NGO, the University of the Witwatersrand, UNC, and UCSF, we established a community mobilizing intervention that sought to address the intersections of masculine gender norms and HIV prevention and risk in the context of a cluster randomized trial. So the campaign really focused on considering the intersections of gender norms and risk, engaging men to question traditional norms of manhood and masculinity, and then also encourage people to take actions in their personal life and encourage men and women in the communities to work together with others to build a gender equitable movement to prevent HIV. The intervention was evaluated with a community randomized trial design with 11 villages randomized to the intervention and 11 to control in the Agincourt Health and Demographic Surveillance Site in Mpumalanga. So there are 6 components to our mobilization work to change the social environment to improve or enable protective behaviors. And the 6 domains are noted in the boxes that make a circle: shared concerns, community consciousness, organizations and networks, social cohesion, collective activities, and leadership. So we came to these 6 mobilizing domains and these ingredients really by synthesizing common elements of community change processes across a whole array of different social science disciplines. And that includes the social movements literature, social psychology, community capacity, and empowerment literatures. And we really sought to identify the ingredients of community mobilization, or those things that have to be present to mobilize a community and make a change. And for those who are interested, this was published in PLOS One in 2013. So while I'm focusing today just on operationalizing one single concept in this sort of greater model, and that's social cohesion, it's important to reiterate that we hope to change all these things across this spectrum of different social constructs and processes. So once we identified these mobilization ingredients, we went about creating activities or intervention components that would map onto the 6 domains that would in turn affect the desired outcomes. So this is just the things we did to try to foment more social cohesion in the communities. A big part of the mobilization process was establishing and training community action teams. And these are cadres of volunteers who are recruited and trained to assist with activities in the communities in every village in order to create sort of a more formal leadership structure and foster sort of a volunteer structure in the neighborhoods. So these teams are also community resources. They disseminate messages, they actually plan and execute activities, and they can become their own new cadre of activists and a voice for diffusion into their communities. We developed workshop content around a number of the thematic goals in our intervention, including things like addressing gender norms and healthy relationships. But we also used these groups to establish some shared goals and some discussion forums where they could talk through some of the issues that they were grappling with and really use those groups as seeds for further discussion. So we made like WhatsApp groups from some of the people that were in these groups. We engaged with local leadership structures to see about engaging stakeholders in the process and aligning goals, building that trust that was talked about this morning on the panel. We sponsored community murals in each village that included content around HIV and working together to sort of foment ideas of connectedness and reciprocity. And we sponsored community events and soccer tournaments to really create larger groups of dialogue and talk a little bit about what HIV means in the communities and try to foster some of that cohesion there. And we also did photo voice workshops to create sort of a common visual thread and build on shared experience. So did it work? Sort of. So this is the part that gets kind of complicated. So we did all these things, and over half the community was reached in some form. We didn't see significant changes in social cohesion in the intervention communities versus the control communities. If you look at baseline versus end-line scores, we saw some increases in the intervention villages, but not significantly different from what we saw in the control villages. But what's interesting is if you look at individual reported cohesion or what people perceived about their communities, we did see that cohesion scores were highly associated with exposure to intervention activities. So we could impact a sense of social cohesion from those who we interacted with, but that intervention didn't seem to diffuse into those who weren't directly exposed to what we did. So if we look at the full picture, that is, did we successfully mobilize communities and increase those 6 ingredients, and did that translate into more HIV testing, we found that community intervention activities worked through direct exposure to the intervention, and that was definitely associated with mobilization scores and a higher probability of testing. But our findings indicate that the impact we're seeing, like I said, appears to function largely through direct intervention exposure of individuals and less so through diffusion of ideas and norms to other community members. So for those who experienced a greater amount of our intervention, the perception of their community changed, and that changed perception was associated with improved testing. So we're still working on this model. We have a current study in the field focusing on improving the full care cascade in a newer and more refined mobilization program aiming at promoting and gaining momentum around treatment as prevention in South Africa, which is still a relatively new concept for folks there. And this is a 3-year mobilization campaign, so we're hoping there's more time to diffuse into the general community than we had in our 2-year model that I presented. Oops. So, in conclusion, I believe that the social contextual factors and social resources, such as social cohesion, they do impact health. I also believe that there is evidence that we can change these factors and that strengthening social resources are going to have broad impacts far beyond HIV prevention. There's evidence that healthier environments and communities with more social resources have improved outcomes for a number of chronic conditions, and I think there's a lot of room for synergy in our work in HIV and other chronic conditions as we try to modify the social environment. Also, dealing with social contextual factors brings us back to the community and what the community wants and what the community needs, and puts the community at the center of the interventions that we're doing. So while I think that there's still a lot of work to be done, I think we've come a long way. We need to improve our programming approaches to impact those latent constructs like cohesion, figure out the right mix of ingredients that we need, how much of each, how long do we stay in the field, how long does it take to build up these components? You know, we saw in the 2-year intervention that I presented that we could change people's perceptions about their communities, but that hadn't diffused to everyone that was in those communities. And so we're looking to figure out sort of where the tipping point might be from galvanizing change in a few or in some to really moving the needle in the curve for the entire group. And hopefully we'll be figuring that out in the coming years. I just want to acknowledge my many collaborators at UCSF and all over that helped work on these studies, particularly Audrey Pettifor, Kathleen Kahn, and Tor Nealons, who've been working with me on these concepts for the last 10 years. And I want to acknowledge the funders that made the work that I presented possible. And I stayed under 15 minutes.
Our next speaker is Sebastian Linnemayr. He is a senior economist at the RAND Corporation and also a professor at the Pardee RAND Graduate School, giving us the behavioral economics perspective.
Okay, thank you so much for the invitation. It's a great pleasure to share my work and my excitement of why I think that behavioral economics is really an expansion of our existing tool set that often yields new insights. It's a framework to think about, and that has helped me think about HIV-related behaviors, and often yields interventions that really are cost-effective. I also wanted to thank Will for spending a lot of time practicing to pronounce my name. Great job. So why behavioral economics, or what is behavioral economics? Luckily, my job has gotten much easier over the last couple of years because behavioral economics by now has entered the public conscience and really has seen tremendous growth and has culminated in a behavioral economist receiving the Nobel Prize in Economics this month. So I think most of you by now have some inkling of what behavioral economics is. So in this presentation, I will focus mainly on the policy implications and also give you 2 examples of interventions that I have implemented based on behavioral economics. When we think about behavioral economics and what it is, I think a good starting point is to think about traditional economics. And traditional economics is important because I think it has had a tremendous influence on policy making. Economists have always had good access to policymakers, and this idea of a rational actor that the traditional economics framework is based on really has permeated policymaking, I would argue. In that framework, people always act in their best self-interest. They always know what's best for them. And if they show unhealthy behaviors such as smoking or overeating or engaging in risky sexual behaviors, it is really that either they lack the information or that prices are wrong. And we've seen this, I think, for example, when you drive through any city here or in Africa, you see posters saying HIV is bad or smoking kills, all these sort of things, when arguably, even in the most remote corner of Africa, people know what HIV is and that it's a serious disease. The second policy lever in the traditional framework is to set prices right, for example, by implementing soda taxes or cigarette taxes. And that has been somewhat more successful, I would argue. But on the intervention side, we've seen a lot of interventions really trying to more or less pay people to do what we want them to do. This sort of contingency management approach that has seen some application in the last 20 years, but I think is more and more, we're coming to the realization that there's a limit to how much we can pay people to do what we want. That we really need to think about how people really act and what drives them. So behavioral economics from this perspective and from this policy perspective, I would argue, really goes way beyond the traditional policy model and really is an expansion, as I said, of the tool sets we have. Because behavioral economics starts explicitly from the realization that we all make mistakes. And it's not just the people living with HIV or the poor people living in Africa, it's all of us. We have cognitive limitations, we have problems with self-control. And if I wanted to contrast traditional economics and behavioral economics visually, I would say that traditional economics really thinks that we are much more like Ned Flanders, who's always in a great mood, always on time, when most of us act much, much more like Homer Simpson, who is always torn between doing what we know is right and what we want to do, and the temptation of doing something that's fun and has a current benefit. So the interesting thing for me as a behavioral economist is not just the realization that we all make mistakes, because that would lead to chaos from a policy perspective. But the interesting thing is really that we make these mistakes over and over in a very, very predictable manner. And behavioral economics suggests that if we know a person's decision-making environment, we actually pretty much can be certain what sort of mistakes that person will make in the future. And as a really, behavioral economics, I think, also has the great advantage that we're very much intervention-oriented. So starting from this realization that it's the environment and the decision-making environment that drives people's behavior, we can then make attempts at altering the decision-making environment, for example, by using small nudges, by using incentives, or I think in the previous session, someone talked about opt-out testing. That is a very clear change in the decision-making environment. And when we think about HIV and other chronic behaviors as a decision-making environment, I will make the point in a minute that HIV is a really difficult and complex disease from that perspective. Behavioral economists have found that people make good and healthy decisions if these following bullet points are fulfilled, and someone in the previous presentation brought up aspirin, so let's use this as an example. So a lot of people, when they have a headache, they immediately and intuitively grab an aspirin or some other medication. And hopefully within 20 minutes or half an hour, the headache will be better. So there's a very clear action and outcome feedback, and we don't have to do a lot of policy to try to get people to take aspirin. HIV-related behaviors, unfortunately, don't fulfill this scenario or this decision-making environment that I just described for aspirin. Most of these chronic health behaviors are, by their very definition, long-term behaviors that we have to do daily. We have to take either ART daily or PrEP daily or use condoms daily over and over and over again. Secondly, and relating back to Homer Simpson, most of these health behaviors are what economists would call investments. So the cost is now and the benefits are far in the future, which leads to a situation where very often people want to do the right thing, but I can do that tomorrow, so they procrastinate. And that's, as I said, it's for me the exciting thing about behavioral economics. It's not just that it deals with sick people, but it's true for all of us. I'm trying to lose weight, and this morning I wanted to have a healthy breakfast, but I had to fly to a very nerve-wracking conference, and so at the airport I opted for the sugary bagel or the sugary muffin at Starbucks rather than having my cereal as I had planned. So it's really this, I think that's a really driving force that for a lot of these chronic health behaviors we have to make all these decisions now and these investments now that only pay off in the long term. Chronic conditions over time also have low salience, meaning they drop from a person's priority list, in particular in resource-limited settings or among vulnerable populations. There are very often other threats to their survival or to their economic well-being, such as having a leaky roof or not knowing where the school fees for your children are coming from in the next month, and HIV often takes a backseat to that. And as I said, once we know this decision-making environment that I just described is quite complex and difficult, we know that certain behavioral biases or systematic decision-making errors come about, such as I already described, that we forget about HIV being an important disease, that we kind of push off taking our medication or engaging in this healthy behavior now and try to do it tomorrow, but then tomorrow turns into today. And I think one somewhat often underappreciated aspect is also affect. Behavioral economists know that when we are emotionally or sexually aroused, we tend to make particularly bad decisions. So that is certainly affect is something we need to focus more on, I think. So what does this all mean for you? As a behavioral economist, I'd like to implement interventions that have at their core behavioral economics insights, such as providing nudges or changing default options and these sort of things. But I think behavioral economics, I already mentioned, is really a framework to understand behaviors and can also be used in a much more supporting role, so to speak. So even in a nutrition intervention, for example, one could try to use behavioral economics to increase the effectiveness of messaging, or a lot of studies, for also those that use novel technologies, have trouble recruiting people or keeping them in their studies. And behavioral economics can really be a very effective and cost-effective tool of thinking why people don't engage with these technologies that we want them to engage with. And in the remaining 5 minutes, I wanted to very briefly talk you through two completed studies that I have done, both sponsored by NIMH, both of them in Uganda, but I think, and both of them also relating to ART adherence. But I think the insights that we're dealing with when we use behavioral economics as a framework to think through behaviors really applies also to prevention, PrEP, and other HIV-related behaviors. In the first study is a very simple study. We gave people electronic pillboxes, and we told them, we know it's hard for you to take your medication every day, but if you take your medication at a high level, there's going to be a chance to win a small prize. And so we try to nudge people in the right direction and support them in their good intention of doing what they already wanted to do, which is to be healthy and to take their medication. And I think it looks somewhat similar, but I think it's fundamentally different from a contingency management intervention where we tell people, go and get an HIV test, I give you $50, go and pick it up, I give you $100. Here, even by Ugandan standards, we used very, very small prices. The price values for our intervention is about $2 per person per year. So when a person came back with their electronic pillbox and they showed about 90% adherence, we let them draw these numbers out of a bag. If they drew a 6, they could win one of these prizes, like a coffee mug or water bottle. And they had this chance every time they came to the visit. And the idea was really here to give a little bit of an additional immediate benefit to taking your medication. And people responded to this tremendously and unexpectedly good. So despite the very, very low price values that we gave out here, the green and red line on this graph are the intervention groups. We managed to push a large fraction of people from mediocre adherence of around 70% or so in the control group to over 90% in our intervention groups. Or put differently, in the control group, we had about 45% of people who took at least 90% of the medication over a 9-month period. In the intervention groups, we had about 70%. So we increased the fraction of people taking the medication optimally by about 25 percentage points using prices that are worth only about $2 per year. So it's really hard to argue that it was the price value or the monetary value of that that made the difference, but it really showed us that we hit people at the right spot, that by providing these small, visible incentives and benefits, people it brought it back to their attention and they tried to do better in their adherence. Going a step further, as I said, for me it's not the price or the monetary value as in traditional economics that we give people. The previous example already gave very, very small nudges. A second study that I just recently completed is giving non-monetary incentives. And that for me is a very important message, that incentives, when I talk to people about incentives, they immediately say, oh yeah, money. But obviously we're driven by very, very different things than money. We're driven by academic prestige, by social norms, by affection to other people, by altruism. So we tried to make use of that and implement an incentive-based study where we don't give out any prizes, where the prizes are really, or the rewards are intrinsic to the person. So what we did is, again, we gave out electronic pillboxes, in this case to adolescents in care, where we knew that youth are very much driven by how they're perceived in their peer group. And every week on Sunday, we sent them back how well they had taken their medication. And in one group, we sent them back, congratulations, Will, you took 70% of your medications this week. And that was really this pure information provision channel that I talked about in the traditional economics framework, because we did see that a lot of people were extremely over-optimistic of how well they were taking their medication. But the interesting part is the second part of the sentence, where to another group, we sent the message, congratulations, you had 70%, but a lot of your friends had 85 or 90%. So we created a social norm, peer pressure, that is, as I said, an incentive that has got nothing to do with money. It touches a different sort of behavior in the person. And I'm currently evaluating this, but we seem to be, in particular, for those who have very, very poor baseline adherence of around 50 to 60%, we're seeing a big upswing exactly towards that 85% mark that we had sent out. In the last minute, for all those who were busy with other things in the last 14 minutes, I wanted to summarize things up. The take-home points. I said that behavioral economics is very different from traditional economics. It's a radical departure in that we explicitly recognize that people make mistakes. The nice thing is that I said that people make these mistakes predictably once we know their decision-making environment. And that hence, from a policy perspective, if we know the decision-making environment of a person, we can make an attempt to change that decision-making environment. And we can then counter these sort of biases or systematic decision-making errors that people tend to make and actually turn around and use them as entry points for our intervention. So those people who are particularly prone to suffer from present bias or who procrastinate a lot have the nice feature that those probably are exactly the people who we can nudge with small incentives that are given relatively immediately to show better adherence, because these are the people who have trouble, thinking about the future very much and making these long-term decisions. So it's not just that we're pointing out their mistakes, but we're really using these same mistakes and behavioral biases as entry points. I'm at 0, so I'll stop there, and thank you again. I would like to thank for the invitation, NIH and NIMH in particular, for funding most of the research, or all of the research that was presented here. And thank you for your attention. I'm looking forward to your questions and or your emails. I'm always open and happy to talk about other people's projects and how behavioral economics can add, hopefully, something to their strategies. Thank you very much.
And last but certainly not least, Emily Arnold, who is an anthropologist here at CAPS at UCSF.
Good afternoon. So I'm the lucky person who drew the slot right before lunch to speak to you all. So I do hope that I can continue to keep people engaged. So I'm here today to talk a little bit about really examining community-level resources, and in particular, the notion of chosen families. I'm an anthropologist by training, and so one of the things I would like to start with is a little bit of an overview on what ethnographic approaches has to offer HIV prevention and care as we consider the 90-90-90 or the 90-80-73. So sitting in a room with an esteemed group of social and behavioral researchers, one might ask, we have probability-based sampling strategies, brilliantly designed, validated, replicated scales and surveys, as well as the ability to conduct focus groups at will to really uncover what are the drivers of HIV in our communities at risk. But one of the things that ethnographic fieldwork, and in particular participant observation, brings to our methodological toolbox is the ability to cover not just what people tell us they do, but what they actually do. Ethnographic fieldwork, or the hallmark of my discipline in anthropology, is built on the basis of participant observation, in which ethnographers spend months, if not years, following the communities that they work with, establishing relationships, conducting informal interviews, as well as observing patterns of behavior, patterns of social relationships that may be fluid and in flux, and also gaining an understanding of how decisions are made in a broader context of social and political inequality. So ethnographic fieldwork, and I am interested in particular with sexual and ethnic minority youth, and by that I mean gay, bisexual, transgender identified, queer identified, in some cases same-gender loving identified, really an umbrella of sexual and minority youth, and who are the most important people in their lives that determine HIV-related health behaviors. And one of the things that I have found, and that has been buttressed by years of ethnographic fieldwork, is the salience of chosen families on people who are chosen kin to provide as well as receive specific forms of social resources or social capital that then have an impact on HIV-related behavior. So you may ask, how are chosen kin determined? What are the ingredients that go into chosen kin? Well, there's been a series of ethnographies going back to the 1970s with Carol Stack's groundbreaking work called All Our Kin that really establishes a number of ingredients that are very important to determine kinship based not on blood, but on choice. Among those factors, we have often geographic proximity, a sense of solidarity or shared commitment. In addition, a willingness to pool resources which may or may not be reciprocated immediately, but that are there to pull on at any time. And finally, an outward expression of caring or love or devotion. So, looking at ethnographies that have been written and produced over the years, Kath Weston here in San Francisco documented the importance of gay families in communities of lesbians and gay men living in the Castro district in the 1990s. That work was extended by William Hawkswood, who worked with gay families among gay black men living in Harlem at the height of the AIDS epidemic. In his work, he found that gay families were essential in providing care and treatment to people who were essentially dying from HIV at that point. And finally, some of the work that I've done with colleagues such as Marlon Bailey with the house ball community, which is an underground community that is made up of houses which basically take the form of chosen families that then organize and perform within community events known as balls. Kin can be conceptualized as social networks and therefore analyzed utilizing quantitative methodologies that really have their basis in sociology. One of the things that social network analysis has contributed is an understanding that social resources flow within social networks. So flows of information, access to material resources, social norms, health behaviors, and of course, disease transmission can be tracked through people's connections to one another. So in the work that I do, I've come to understand that social support provided from members of one's chosen family are actually very important for us to understand and track in regards to HIV-related health promotion and behavior. I'm interested in several dimensions of social support and pull on the work of Luxem Petosa to describe emotional support, which might be, do you have someone in your social network who understands you, whom you can discuss important matters with? Another important dimension of social support is informational support. Do you have an individual in your network who can provide advice or information to you? Another very, very important and really crucial aspect of social support, particularly for those of us who work with marginalized communities, impoverished communities, are sources of instrumental support. Do you have someone who could loan you $40? Do you have someone who could give you a place to stay for a night or two? And finally, drawing on the work of Linnemayr Darbus and Megan Lewis, looking at HIV-specific forms of support. Do you have someone in your network who encourages you to get tested every 6 months? Do you have someone in your network who will talk to you about using condoms? If you're living with HIV, is there someone in your network who will take you to the doctor? Working with sexual and ethnic minority youth, we've come to document that houses and gay families truly are chosen kin for these individuals. And as chosen kin, they provide an array of social support that is related to HIV. Now, there are a couple of aspects of the social support that are very important to understand as we begin to think about intervention development and working with these communities. The first is that social support is gendered. In a house or a gay family, there often are mothers or fathers, and they provide very different forms of HIV-related social support, as well as other kinds of social support. So in developing interventions, we need to acknowledge that we must involve both parties in our prevention interventions. Similarly, support is often reciprocated among people who have a sibling relationship, that is often expected within those kinds of dynamic relationships. And finally, community events such as prevention balls, which I'm going to get into in a moment, provide a place to reinforce chosen family ties, as well as to reiterate social norms or a form of social capital that the community as a whole holds, particularly around health behavior and HIV prevention and care and treatment. So it's always very hard for me to talk about the house ball community without a couple of visuals. This is a flyer from a ball that was held here in the San Francisco Bay Area in Oakland several years ago. And one of the things that you might notice about it is that it is, if you look on the left-hand side of the flyer, it encompasses an array of gender and sexual communities. We have women, we have butch queens, we have butch queens up in drags, and we have femme queens. An entire variety of sexual identities, gender expressions are included and indeed even celebrated within this context. If you talk to young people who are involved in chosen kin communities, they will tell you that these chosen kin actually perform and provide essential forms of support. Here we have a young transgender woman of color who basically says, I think there is definitely a lot of things that are necessary to my well-being that happen in the house. We definitely encourage each other. I've actually had these conversations with people like, let's go get tested. Let's go tomorrow. It doesn't take long at all. So again, we see specific HIV forms of social support circulating within these communities and conversations happening explicitly. Within gay families, there's a young man who reports, by the way, who does not have a relationship with his biological father, who reports that basically his gay father has acted as a surrogate father for him. My gay father always instilled morals and values and good advice in me, and he was as if he was really my father. When we do talk or text, it's always encouraging things like, what's going on? Are you working? If you're not working, are you looking? Do you need help with your resume? And when I told him I was applying for school, he was like, do you have any fees that you need covered? So here we can see definite form of instrumental support taking place. And again, particularly in socially and economically marginalized communities, all of these forms of support become very important. So the content of the social network is very important and contributes to the well-being of young people who are actually engaged in these networks. But from a social network analysis perspective, one might ask, what are the structural characteristics that might matter when we think about HIV promotion, HIV health promotion? So now I'm going to try to use my little pointer. So for those of you who are not social network and analysts or experts in the field, I'm not looking at you, Carl. This is let's see. On the left, we have an egocentric network, which you can see actually has a number of alters who are not very well connected. We would refer to this as a network that has low density. Oh wow, I'm moving on up here. These become really important when we think about health behavior, because if you're positioned within a more dense network, more people are going to be monitoring your health and well-being as well as your risk behaviors. And so it actually matters how dense your network may be. This sociometric graph on this side actually illustrates a different concept that we are interested in social network analysis, which is that of homophily. That you can, if in a brief summary, would be birds of a feather flock together. If you see here in this complete network, we have groups of individuals who cluster together on these axes. And while they may be relatively well connected, there are also a few folks who are brokering relationships between these larger clusters. So, in a small sample of about 275 youth attending balls here in the San Francisco Bay Area, we actually examined the social and structural characteristics of the networks, looking at size, density, again, who knows who in your network, and homophily, how different or alike are you from the people in your network? And then finally, the provision of specific forms of social support, emotional, instrumental, informational, and HIV-specific, in order to determine if those were related at all with HIV-specific outcomes. And we found that HIV-specific support and homophily were the things that mattered the most. For participants who had the highest threshold of HIV-supportive alters in their networks, they were 40% more likely to have tested in the last 6 months in our sample. For those similarly, those who also had the highest percentage of HIV-specific supportive alters in their networks were, again, 25% less likely to have engaged in unprotected anal intercourse in the last 3 months. In multivariate analyses, we found that HIV testing in the past 6 months was associated with social support for condom use, instrumental social support, and age. Similarly, for unprotected anal intercourse in the last 3 months, HIV-specific support, homophily based on sexual identity, and HIV status were all related. So how do we take these findings and use them to develop well-grounded, situated interventions? Because that's really what we are here for, is to address the HIV-related health disparities in these particular communities. I'm going to talk to you a little bit about a study that we just have funded and are getting ready to go into the field with, called the We Are Family Study. The We Are Family Study, which is funded by the CHRP, the California HIV Research Program, is using kinship networks, again, chosen kin, to reach the 90-90-90 for sexual ethnic minority youth here in the Bay Area. And there are a few things that I want to point out about the We Are Family Study. This is a study, an intervention that's made up of 4 components. The first is group-level sessions. The second is community-level events, such as balls. The third is an mHealth approach, an online network-based approach. And the fourth is actually providing culturally competent services. So looking at my incredibly busy slide, we took our findings from our formative research as well as the quantitative survey we had done, and we recognized that we needed to identify existing houses and gay families. And within those families, we then needed to identify particular leaders, mothers or fathers, or gay, in the case of gay families, gay mothers or gay fathers, who would partner with us because they already provide what is known as intravention within the community, so that we would be able to bolster the HIV-specific forms of support in these networks so that all of the alters within those particular kinship networks would then become sources of HIV-specific forms of support. Looking at the issues around homophily, we recognize the need to develop an array of materials that acknowledged and provided information to a diverse array of youth who encompassed gay, bisexual, and transgender identities. Finally, we used an mHealth platform to increase the size of the networks and also the reach of informational support that young people might have access to. And I'm going to close by just showing you a very brief, if I can get it to go, wireframe from our app, where you can see we have informational support here with HIV-based knowledge, and then social norms that are reinforced, that are actually produced from the young people in our community to promote HIV-related well-being and health. Thank you so much. This is my contact information, and I'd like to gratefully acknowledge the funding I've received from NIMH as well as CHRP.
And as you can see, we have quite a distinct array of different disciplines represented, but also some significant commonalities, particularly common goals. And we're going to go ahead and take some questions. We have cut into lunch a little bit, but remember, we started a little bit late. And so if you'll notice, there are some microphones up in the aisles. If you have questions, as you're able, please come up to the microphones. If not, we have staff Daryl and Lauren who will be able to assist. So if you can, please come up to the microphones if you have questions, and we'll go ahead and start the queue. We'll alternate. We'll start with where the gentleman there is standing, my left, and then my right.
Hi, is this on? Yeah, I think so. My question is to Dr. Sevelius and Dr. Arnold. Have you done much work with trans men? And the reason why I say this is because my agency, I work with Black MSM, and I'm finding that trans men are there, but you can't really see them because they can pass like you wouldn't believe. Particularly if they get the breast removed, take the testosterone, go to the gym, you wouldn't know that these are trans men. And I spoke to some of them about that, and they said that they tend not to get involved with HIV for two reasons. One, because they identify as men, and so this whole question about trans men, and also because trans men who are HIV infected usually got it by having sex with a man, but in a heterosexual way, and they don't want to think about that. So I'm just wondering if you've seen any work in your houses or in your work with trans men, and anything you can tell us about them.
I'll let you go first. Okay. Thank you for that question. Yes. I think there's still a lot to learn about trans men and HIV risk and sexual health. What we do know about trans men are that the rates of HIV among trans men are much lower than among trans women. So in transgender communities, the focus on HIV prevention and treatment has really been on trans women because that's where the disparities are most pronounced. We do see that the trans men who, as you alluded to, there are some trans men who get involved with HIV prevention efforts, and we see that those are trans men who have gay and bisexual identities. And so when we do talk to trans men about PrEP in particular, we find that trans men who identify as gay and bisexual men prefer to receive their HIV prevention and sexual health services from organizations that serve gay and bisexual men, because that's where their identity is, that's where they're most likely to seek services. But that trans men actually have been pretty early adopters of PrEP and really interested in PrEP because it's actually very gender affirming of their gay and bisexual identity. Whereas trans women have been more resistant to the idea of PrEP because it's been marketed to gay and bisexual men, and they really seek to distinguish themselves and their identity from that gay and bisexual men's sort of prevention movement. So like I said, I do think there's a lot more to learn about trans men, but there are some things that we can build on, and also I think there's a lot to learn about protective factors that gay and bisexual trans men may be privy to that that kind of drive the lower rates of HIV that we see among trans men. If you want to add to that.
I don't have very much to add. The communities that I work with are really dominated in terms of transgender individuals who are involved in them by transgender women. However, very recently, there have been trans men who've become more involved in the houseball community here in the Bay Area. And I think one of the things that we need to note that Jay's talked about is that we have to not assume what their sexual identity may be. So I've had trans men in groups of mine, focus groups, that are interested in the We Are Family study but who identify as straight. And so making sure that we also attend to those variations in terms of our intervention activities as well as our survey design and the eligibility criteria so that we're inclusive.
And unfortunately, we have time for one more question. So we'll go ahead and take your question on the right here, on my right.
Thank you. This question is for Sebastian, actually. So I wanted to get your thoughts about some special considerations in terms of behavioral economics when we're thinking about adolescence, and which particular factors are maybe a little bit more salient or don't work so well when we're working with adolescents.
Yeah, that's a great question. Thanks a lot, and I don't know. I actually don't know about behavioral economics work that's specific to adolescents, and I think it's a wide open research area. There's also, I've started also thinking about like gender differences in some of these biases, but clearly in adolescence one might expect that adolescents tend to be less future-oriented in a lot of ways and maybe are even more privy to giving into current temptations and these sort of things. So that was one of the reasons why we implemented the second intervention I talked about among adolescents, and because we knew from talking to them that this group cohesion and peer pressure is certainly something that was very important and somewhat specific to them. But I don't have a general answer to that, and if you have any students who want to work on that would be great. Thank you.
And if you have any other questions, they'll be around during lunch. Thank you so much.